Progress.
Going to focus on structure that much because you have gone through this somewhere else. Okay, in the anatomy, in the this is basic anatomy. I'm going to mostly focus on clinical functions, clinical implications of placenta, membrane, and cord. Okay, you all know that it is a highly specialized feto-maternal organ. Okay, this is not only arising now; it has two components: fetal part and maternal part. Okay, uh, have you all? I think you all have seen placenta, right? Has any? Have you all seen placenta? You are not talking now.
Sir,
Anyone?
there are three more groups to do IVG appointments. Sir.
Okay, nobody. Yeah, some of them have not seen. No. Okay, so it is a no. It is a structure you would have seen at least in a picture. No. So once the baby is born, the placenta is attached to the uterine endometrial surface, and it after the delivery of the baby, it it gets basically we call it detached from the endometrium, and it slowly comes out. We need to do an active maneuver to remove the placenta. That is a structure. It is called active management of the third stage. We do something called control contraction. We apply, once the baby is born, we put the clamp to the umbilical cord and separate the baby and apply a little bit of traction to remove the remove the placenta from the abdomen or from the uterine cavity, which we are going to come across. We are going to learn it very in many places. Okay, so it is a feto-maternal organ. A fetal part is derived from a group of cells called trophoblastic tissue and extraembryonic mesoderm. This forms chorionic plate. When you read, I think I'm not going to do the embryological origin here, but fetal part is derived from trophoblastic tissue and extraembryonic mesoderm. And maternal part is derived from the endometrium. There is a maternal part as well as a fetal part. You should know that maternal part is derived from endometrium, fetal part is from the trophoblast and extraembryonic mesoderm. This trophoblastic cell rapidly proliferates and forms villus and extravillus pathway. Okay, so through this action, actually, there are two types of cells in the trophoblastic pathway. There is a group of cells called syncytiotrophoblast that actually erodes the capillaries and forms the anastomosis with the other lacunae. Okay, this around the fourth week, all this complete vascular network is established. So I think I am actually unable to describe the embryological origin. I am going to focus mostly on clinical aspects. As I said before, you should know these things. You have gone through this in the embryology, or when you would have come across, but maybe you have forgotten. Just activate your kind of memory cells and try and recap, or go home and read. There are two pathways. Okay, villus stem cells, extravillus pathway, and villus pathway. Okay, so this is just recap it. It is very useful, and somewhere you need to connect it with clinical application. Okay, so this is actually there is a now this forms a villus-like structures. This villus structure, now look at this picture. This is extraembryonic mesoderm, and this set of cells are called cytotrophoblastic tissue, and this is syncytiotrophoblastic tissue, and there is a connection. This forms lacunae. So these villus structures are exposed to the lacunae. This lacunae gets blood from the maternal side, and it fills, and whatever the exchange occurs in the tertiary villi, terminal villi part. Okay. So this is again it is a plate-like structure. This is the placenta. This is the term placenta. There is an umbilical cord, umbilical vein, and two arteries, umbilical arteries. They form a connection, and they, finally they reach the villus structure. The small capillaries will reach the villus structure. Villus structures are actually bathed in the lacunae, this blood lacunae. This is called intervillus spaces. In the intervillus spaces, the sinuses or the blood vessels from the maternal side will open, and they will pump the blood to the intervillus structures. These villus structures are completely bathed within the blood. Okay, this forms these structures, whatever the villus structure covered by this trophoblastic tissue is called villi, or not villi, cotyledons. This placenta, it forms a cotyledon. So this picture, now if you look at this picture, this will explain. Now you need to draw in, understand this villus structure covered by all this finger-like projection. These finger-like projections are called cotyledon. When you see a live, once you go to the labor room, you will see the midwives and the nurses. Once the placenta is delivered, we have to check whether all structures are completely have come out. Membrane should be there. The placental membrane is there. It's a small membrane that is covering the placenta, and cord should be completely come out. And also placental cotyledons. All these cotyledons, the midwife will separate, keep it in the hand and separate it and see whether all cotyledons are there. Sometimes if there are any possibilities of missing cotyledons, we may have to check whether it is inside the uterine cavity. Leaving a cotyledon can lead to excessive bleeding or infection later. Okay, so these are the structures. So placenta as an allograft. So you should know that placenta is a foreign body. It has maternal as well as fetal component. And when something is implanted in the body is usually trying to reject it. But fortunately, pregnant women have kind of suppressed immunity. And this suppressed immunity and the changes that occur in the pregnant women will help the women or the uterus not to reject the placenta. So it can be used as it is considered as an allograft, or it is accepted by the body. In the meantime, this placental tissue, amniones and all, we use clinically as an allograft also. In lots of surgeries, we use the membrane from the placenta. We take it and we keep it and preserve it, and we use as a fresh kind of allograft. For example, we do a surgery called neovagina creation of neovagina. There is a condition called Mayer-Rokitansky-Kuster-Hauser syndrome or Mullerian dysgenesis. Some women, although genetic blueprint is a female, they are born without a vaginal tissue. So we create a vaginal tissue and we cover that tissue with an amnion, and this will form as an epithelium. So we use this placental membrane as an allograft. Interesting, isn't it? So this is the full-term placenta. If you look at this picture, you will see the cotyledons covered by this fetal part is covered by amnion, and cotyledon, this part, maternal surface, is covered by cotyledons or endometrium. There are these finger-like cotyledons, and usually 14 to 20 is there. There is no strict number as such, but when something is missing, you can see. See, this is the natural placental surface. This was taken soon after the delivery of the baby. So full-term placenta is a discoid shaped structure. Diameter is 15 to 20 millimeter. Thickness is about 3 centimeter, and weight is about 500 to 600. This anatomical description is very, very important, because you can correlate with when you look at the macroscopic picture of the placenta. If a trained person looks at it, they will macroscopically, we can say this is a small size placenta. Sometimes placenta is very small, especially if there is an IUGR, preeclampsia, or any kind of conditions that is arising from placental insufficiency. Any problem with the placenta, placenta will be very small. Sometimes placenta becomes calcified. Sometimes evidence of infection and abruption. Abruption is, can somebody say what is abruption? Who has done obstetric appointment? Can somebody say abruption? What is abruption? What is abruption?
Removal of the placenta?
Not removal. It's a naturally placenta gets separated, prematurely separates from the uterus and cause bleeding and also even IUD. So natural separation. Then in this area, in the placental cotyledon surfaces, we will see blood clots, large blood clots. In that means she has started to bleed from the maternal side. So we soon after the delivery, if we see an abruption, an area of clot, we know she has had an abruption. But there are lots of features to find out clinically. Obviously, if a patient with abruption comes, we know clinically it is an abruption, and we know when we do a CTG of the baby, we know there is an ongoing abruption, and we quickly do a cesarean section and deliver. But after when you see the macroscopic feature, you can stay. Okay. So maternal side has about 15 to 20 cotyledons covered by thin layer of decidua basalis. Fetal side is entirely covered by chorionic plate or amnion. Okay, so number of vessels diverge or converge toward the umbilical cord, and then it goes up to the villi. Okay, maternal and it is, as I said before, these are whatever I described. The decidual plate between the maternal and decidual plate and fetal chorionic plate. There is this is fetal chorionic plate. This is called decidual plate. In between these two plates lies the intervillous space. This intervillous space is pumped by maternal blood, and within which structures bathe. Those structures are called villus structure. Okay, villus structures are bathed by the blood in the intervillous space. I told you before. So this terminal villi, at this point, this is the place, terminal villi. This is the place where most of the feto-maternal exchange occurs. So this is a structure which actually primarily functioning as a functioning organ of feto-maternal transport or exchange. Whatever the oxygen diffuses to the baby, and then carbon dioxide and all the other substances come back to the maternal blood side through the placenta. Okay. Apart from this exchange, metabolism is one of the key functions. In early pregnancy, placenta synthesizes glycogen, cholesterol, and fatty acids, and transportation of gases, nutrients in both directions, because it has a large surface area because of these cotyledons. And villus structure, it makes the surface area, a big one. Okay. And transport occurs by simple diffusion, facilitated diffusion, and various other means. And apart from this, oxygen, carbon dioxide, glucose, amino acids, vitamin, and hormones also can get transported across the placenta. There are certain things that don't get transported. So, for example, IgM antibodies are big ones and they don't get transported. IgG antibodies can get transported. Some viruses, some bacteria can get through the placenta, some don't. Okay. For example, Rubella is one infection that can cross the placenta. Parvovirus. Likewise, there are certain viruses and bacteria that can cross through the placenta and cause problems. And excretion of waste products such as urea, uric acid, these are again drugs and metabolites, infection agents, all these can be transported. A knowledge about this transport, basically what kind of things that are getting transported are important. When you read whatever the things that get transported, actually there is no other ways to know, you should kind of remember it, because there you can't work it out. If you know this thing is getting transported through the placenta, that's it. So you have to kind of maybe by not to by heart, but to come to an understand. And when you practice, when you go to obstetric wards, you should know. When we will sometimes you might get questions also regarding the substances, agents, and microbiome that can cross the placenta, and substances that can't cross the placenta. All these are important. I can't put a list now, but you may have to read and understand. Right. I will talk about clinical implications. There is a condition called placenta previa. Can somebody say what placenta previa is? Hello, guys. Are you all awake? What is placenta previa? Placenta is located at the lower segment of the uterus, that is covering the os. There are 4 grades, grade 1, 2, 3. If the placenta is reaching the internal os, that is grade 1. It is just crossing partially, grade 2. It's crossing completely, grade 3. And it crosses and comes out from the other end, that is grade 4. Likewise, sometimes we grade it major and minor degree placenta previa. The problem is, when the placenta previa is there, you can't deliver the baby vaginally. And the other issue is, once the placenta is delivered, the endometrial raw area tends to bleed, especially if it is located in the lower part. And as a consequence, they face a condition called postpartum hemorrhage or obstetric hemorrhage. Placenta previa, and sometimes more than that, there is a condition called placenta accreta. Placenta can get attached to the previous scars in the uterus. If the patient has undergone myomectomy surgery or cesarean section, that can get attached to the placental scar, and very difficult to, at that time, if it is attached, it's very difficult to remove the placenta. Then it will get attached to, it will further cause bleeding, and sometimes they will end up in hysterectomy, removal of the womb. These kind of patients can end up in this kind of bleeding and obstetric hysterectomies. That is called abnormal adherence. Placenta accreta, something called placenta increta, or placenta percreta. You will learn these things later. Preeclampsia. Can somebody say what is preeclampsia? Ashan AJ. Ashan, what is preeclampsia?
It's an increase in blood pressure during pregnancies.
Yeah, increase in blood pressure associated with some other problems like proteinuria. So this condition is actually originating from the placenta. We learned that there is a cytotrophoblastic pathway. Cytotrophoblast, there are 2, it multiplies and it goes and invades the intima of the spiral arteriole of the maternal side. If they don't, that when it invades, these spiral arterioles will become wider in diameter. So it goes and so the resistance will reduce. So cytotrophoblastic cells will go and invade the intima of the spiral arterioles around 16 to 20 weeks time. If this happens, this become a less resistant system because of the diameter. It dilates a little bit. If invasion is defective, sometimes trophoblastic cells don't go and invade the endometrium. We don't know why. It's genetically. If this happens, they remain as a resistant system with high resistance system. So this high resistance system will release lots of chemical agents or chemokines, endothelins, and various things to the blood substances to human body, and mother in return will develop high blood pressure, proteinuria, and some other endocrine damage. And this can lead to not only placenta preeclampsia and poor blood supply to the baby and IUGR as a consequence. So you will again will come across what preeclampsia is, what IUGR is, and all the other complications. Okay, IUGR, growth restriction. When there is a poor ischemia or inefficient blood supply through the placenta, growing fetus will get less blood supply, and invariably it will affect the growth of the baby. There is a condition called erythroblastosis fetalis. This happens in Rh negative women. If the baby is positive, if there is a fetal-maternal hemorrhage, blood of the fetus will mix with the mother, and that will form antibodies. These antibodies will remain IgG antibodies. If it is an IgG type, it will remain as a memory in their blood, memory cells. When they have another child, these memory cells, IgG type, will go and cross. If it is a positive, that will cause immunization of that second baby, and they become edematous, anemic, and they will become anemic, and condition will develop as that condition is called erythroblastosis fetalis. Rh isoimmunization. If we identify that, if there is a we do some blood test to identify the rise in titer of the antibodies. With rise in titer, scans, using scans, we can find out whether there is evidence of fetal anemia, and we do intra-abdominal blood transfusion. We can transfuse the baby when the baby is inside the uterus and save the life of the baby. And sometimes gestational choriocarcinoma is also a very rare disease, a choriocarcinoma that occurs in the placenta. As I said, placenta is implicated in PPH. If you don't remove the placenta completely after the delivery, the a small cotyledon or a membrane inside the cavity, that will lead to heavy bleeding, including postpartum hemorrhage. Placental insufficiency is a condition in which placental tissue will not supply enough blood to the baby, and placenta will act as a high resistance system to the baby, and baby will find it difficult to extract oxygen from the mother, and invariably growth restriction will occur. What is growth restriction? And the other problem is sometimes they can end up in placental abruption. Placenta also separates prematurely, leading to IUD. Sometimes if you don't do it in appropriate time, or if you don't act fast, that will lead to IUD, placental abruption. Placental microbiome, a group of bacteria, fungus, and microorganisms that live in the placenta, is implicated in many of the maternal disease conditions and fetal conditions or neonatal conditions. This group of organisms are called microbiome, and it is a debated topic, and it's a new area. So you will come across in microbiology. I'm just outlining this. Okay, I'm not going to go into detail. Placenta, in practical terms, when we do ward work, when there is an IUD, sometimes if the baby dies inside the uterus, or if there is any severe incidents like abruption or any infection involving the placenta, we send the placenta to the pathologist. Our pathological department will receive the placental piece, and they will examine microscopically and microscopically, macro and micro, they will give a conclusion whether this is a mostly this could be due to an infection, this could be due to placental insufficiency, or this could be due to some other conditions, whatever. They give a range of information, and that is very, very useful. So always, as a doctor, when there is an IUD, you should take the consent from the mother and send the placenta for histological assessment. Okay, and there is a component in the placenta, a composite structure. Extra fetal tissues and maternal tissues form a membrane called periplacental membrane. Okay, this is the placental membrane, vessels, amnion, and chorionic plate. And this is after 20 weeks, this is the membrane, placental membrane. It has a little bit of syncytial knots as well as blood vessels involved. Just to know, we normally this membrane will transfer lots of micro kind of substances. Okay, so it's a thin layer called placental membrane. So whenever you see a placenta, you will see the placental structure, cotyledon and amnion in one side, and under that you will see the placental membrane. Spaces, and the placental membrane basically separates maternal and fetal blood. Okay, so end of this is the placental structure. This part is called placental membrane. So it has chorion, it has amnion and blood vessels. Okay, and lots of it ends when you take a placental structure, you will see that end of that placenta, there are the membranes you will see. An umbilical cord, usually 2 arteries and 1 vein surrounded by mucoid connective tissue. It is called Wharton jelly. This again you would have come across at some point in subjects. And 1 or 2 centimeter in diameter. Length varies. Usually attached to the placenta in the center. Okay, here. This is the placenta and attached to the baby. Umbilical cord develops from and contains remnants of yolk sac and allantois. It develops between 4 to 8 weeks, and sometimes some short cords. Some babies have short cords, some babies has long cords. If the long cords are there, it can wrap around the neck, cord around the neck. That can lead to a lot of complications. Sometimes at the time of delivery, you may find it difficult. But if there is a cord around the neck, we can detect it in the CTG, and we will do a cesarean section and deliver. Or sometimes we'll expedite some form of delivery. Okay. Velamentous insertion of the placenta is, at the end of the placenta, placental edge, blood vessels appear unsupported by the placental membrane. This membrane, sometimes only the blood vessels that velamentous, so membrane cord inserts to the place where it is not supported by the membrane. So that can get damaged at the time of delivery, and bleeding actually occurs from the baby. Okay. Even vasa previa is blood vessels crossing the internal os. When the placenta is applied to the lower segment, when the membranes can cross the with a small membrane can cross the placenta. So internal os. When we do artificial rupture of membrane, when we do surgeries, we may accidentally damage the vasa previa. That will lead to a torrential bleeding from the baby and death. Okay. Any questions up to now? So velamentous insertion, it is not actually a usual insertion. Okay, so it comes and it attach to the placenta without a membrane. Any questions up to now? We talked about range of clinical implications of placenta and membrane. So actually, this velamentous, these are some MCQ things. You don't necessarily, you will see it. It's a rare condition. Normally, the membrane, cord comes and inserts to the placenta in the central part. No, so rather than that insertion, it inserts to the edge of the placenta. Okay, so and along the blood vessels around, it runs along the membranes. Sometimes, if it happens, this also can lead to vasa previa. Vasa previa, we commonly, we ask a lot of questions about vasa previa, although it is not, frequently seen. Okay, just read about this and see some pictures. You will understand, and maybe in clinical, when you go to the clinical practice, you will come across more and more cases. And sometimes congenitally, umbilical artery can be missing. When you do, when you see, when you do a anomaly scan, we do a scan around 20 weeks, and there should be like this. There should be 2 umbilical arteries and 1 vein, umbilical vein, and 2 arteries. In some patients, there is only 1 vein and 1 artery. That is an abnormality. But usually this is attached with a kind of, it is associated with some other abnormalities, absent GU problems, genitourinary problems, and some other problems. So when we see single umbilical artery, we will do a then full anatomical survey to find out some other problems. So whenever routinely, if you come across a patient with absent umbilical artery, we should refer for an anatomical survey, or we call it anomaly scan, full anomaly scan. And cord blood banking. This umbilical cord, cord as well as placenta are rich in stem cells, and that can be safely stored and used to treat array of disease conditions that can happen later in their life, or you can be used to treat their siblings, like mostly cancers. Okay, so this is even available in Sri Lanka in private sector, cord blood banking facilities. In Western countries, they even most of the women, they opt to save their child's stem cells for future purposes. And umbilical artery Doppler velocity. When the baby is growing, we can measure, we use the Doppler waveform. We look at this, we do a scan, and we do a special thing called Doppler study, and check the waveform of the umbilical artery, and we can say whether there is a resistance, whether there is a good flow, whether there is a problem. So based on that, we we assess the severity of the growth restricted babies, and we can time the delivery also. So this is very widely used, and maybe we are going to discuss later also. These are umbilical artery Doppler waveforms. Membranes, as I said, yes, membranes also has the function of autocrine regulatory functions, and it secretes and protects the fetus. Any questions? So placenta is a feto-maternal organ. It has lots of functions, and it is actually the machinery that supplies blood, the oxygen to the baby, and placenta is involved or implicated in many of the clinical conditions. If you work in an obstetric unit, you have to always think, could it be from placenta? Could it be from placenta? Bleeding, could it be from placenta? Premature birth, could it be from placenta? So is mostly involved in obstetric practice. So just whatever the anatomical, embryological origin and function and clinical implications are very, very important when it comes to obstetrics and gynecology. So any questions? Anything that you didn't understand, I can revise or I can talk to you again. Okay, then. And in that case, I will end the presentation. I know it's a small, I will share the presentation with you. Mostly this is clinical, and you will, I can only give an outline in this lecture. Okay. Okay, then I'm concluding the lecture.
Thank you, sir.
Recording stopped.